We move to our next speaker, Dr. Pooja Patil.
Good afternoon, everyone. I would like to thank AIOC and EPOA for giving me this opportunity. So today I'll be presenting my study on clinical outcomes of surgical management in recurrent corneal erosions. Recurrent corneal erosion is not only an incidental disease but often a chronic and relapsing condition posing challenges to both the patients and the clinicians. So patient usually presents with a previous history of ocular trauma or corneal dystrophies, and the pathophysiology is generally attributed to anomalous structural findings in epithelium, basement membrane and Bowman's layer. So the aim of our study was to assess and compare efficacy in resolution of symptoms, recurrence rates and complications among various techniques in the surgical management of RCE. So this study, it's a retrospective descriptive study which was conducted at a tertiary eye care hospital in Coimbatore. So inclusion criteria was episodes of RC, 3 or more episodes in the past 1 year, and patients with corneal dystrophies or previous surgical intervention were excluded. So preoperative evaluation included detailed history, refraction, slit lamp and fundus evaluation, and based on the surgical procedure that they underwent, they were divided into 3 groups. First is alcohol delamination, which was done following Dua's protocol. Second is phototherapeutic keratectomy. Here the central 6.5 mm was the PTK zone where 15 microns ablation was done, and the peripheral 9 mm was the hyperopic zone which was corrected for 0.5 diopter to compensate for the refractive shift. And third is the diamond burr superficial keratectomy which was done using an algae brush. So this is a video of diamond burr polishing. Here, under topical anesthesia, the epithelium is debrided using wet cotton buds. Then, a 5 mm diameter diamond burr is used to polish the anterior stroma. So, the polishing is only limited to the anterior stroma, and care is taken not to induce irregular topography by applying undue pressure or staying at a single area for longer time. This creates a smooth surface which will help in faster epithelialization. Then the case is closed with antibiotics and bandage contact lenses. So post-operatively, topical antibiotic drops and lubricants were given and BCL was put. Additionally, topical steroids were added after the epithelium healed to prevent subepithelial haze, and patients were followed up for 3 years. So 30 eyes of 30 patients were included, out of which 5 underwent alcohol delamination, 11 underwent PTK and 14 underwent DBSK. At 10 days follow-up, epithelial defect healed in all 30 eyes and resolution of symptom was also seen in all patients. At 1 month follow-up, mild subepithelial haze was noted in 2 patients of alcohol delamination and 4 from PTK group, which was managed medically and resolved at 2 months. BCVA was similar to pre-op BCVA in all cases. So in alcohol delamination group, 4 out of 5 patients showed recurrence, which were out of so 2 of them were managed with DBSK and did not show recurrence thereafter. One patient in the PTK group showed a recurrence which was managed medically, and there was no recurrence seen in the DBSK group. Dua et al. Reported a success rate of 92% following treatment with alcohol delamination, with only one treatment failure. However, in our study, almost 80% patients showed recurrence at the end of 1 year, indicating higher failure rates in our study. LC Chan et al. Reported no significant differences in PTK and alcohol delamination in terms of resolution of symptoms, recurrence rates, and post-op haze. Studies have reported an recurrence of 42% after PTK. However, in our study, only 9% patients showed recurrence, indicating a better outcome in our cohort. Wong et al. Reported that DBSK had significantly less recurrence rates as compared to epithelial debridement. In our study, there was no recurrence seen in the DBSK group. Also, there was no significant post-operative haze, so reinforcing the better results with DBSK. The strengths of our study were the comprehensive design. We studied alcohol delamination, PTK and DBSK directly. Also, the follow-up period was for 3 years. However, patients with corneal dystrophies were not included, so these results cannot be extrapolated for them. To conclude, alcohol delamination shows good resolution in the immediate post-operative period but has higher recurrence rates. Comparatively, PTK and DBSK has good resolution with minimal recurrence rate. Additionally, DBSK requires little surgical skill and a very inexpensive equipment, making it a prefer modality in patients with RC not responding to medical management. Thank you.
So what was the principle behind doing these keratectomies or superficial burring for the cornea? What is the principle? What is the microsurgical or the anatomical principle behind it?
Ma'am, there is usually
Why do erosions happen in the first place?
because there is problem in the basement membrane of epithelium, which will lead to defective adhesion of the epithelium to the Bowman's layer. So by doing
What are those?
hemidesmosomal attachments are defective. So with these procedures, we try to create a smoother surface on the Bowman's layer, which will enhance like proper hemidesmosomal attachments will be formed, and the recurrent attacks can be prevented.
Did you study the effective? Was there any change in effective CCT or any change in effective corneal thickness?
Corneal thickness was not assessed, ma'am.
Were there any long-term medications also continued in patients, and was the treatment post-operative management with the medications anything different in the 3 arms?
Ma'am, prednisolone drops, like steroid drops, were given mainly for the PTK group because subepithelial haze was generally seen in the PTK group. Otherwise, the treatment was same, and it was continued for post 1 month only, not after that. No long-term medications.
What are the indications for doing PTK in your cases? Why do you need to go for a DBSK? Only PTK, why did you go for that? Because it is more cost, that means
It's more expensive.
expensive, no?
Sir, actually it's a retrospective study, so the treatment was decided by the surgeon at that time, depending on the affordability of the patient.
So there was no form of randomization. There was no reasoning behind using one over the other.
No, ma'am. Actually, alcohol delamination was the sample size is lesser because we were seeing high recurrences. It was not done later in the study, but these two there was no randomization. It's actually a retrospective study.
Thank you.